The ACL is one of four main stabilizing ligaments of the knee. It's inside the joint and runs diagonally, and is very important to stabilize the knee in the front to back direction as well as rotationally. And it's very important to have a functional ACL to participate in cutting and pivoting type sports. The ACL is important to stabilize the knee and allow patients to quickly cut, pivot, and change directions without the knee giving out on them. Typically, the ACL is injured with a non-contact hyperextension pivoting type moment, such as landing from a jump in soccer or a layup in basketball, sometimes from pushing off and changing direction. Also, it can be injured with direct contact, such as a tackle from the side, or even in high energy falls or car accidents. When an athlete tears their ACL, typically they'll have this story of hurting their knee, falling down, hearing a pop in their knee, and then when they get to stand up, it's too painful to stand on, or it feels wobbly and not like it will support them. Also, most patients will see a large effusion or a lot of fluid on the knee. It blows up like a balloon or an orange. You kind of lose definition of the kneecap. An ACL rupture is diagnosed with a clinical exam called the Lockman's maneuver to assess for stability of the shin bone on the thigh bone, as well as a rotational pivot shift maneuver. That can be quite painful though, and is typically reserved for the operating room. And we also use MRI to confirm ACL rupture, as well as to look for other intra-articular pathology such as meniscal tears, bone bruising, and cartilage damage that is common with ACL ruptures. ACLs can be treated both surgically and non-surgically depending on the patient. For most athletes, high school, collegiate, or recreational athletes, ACL reconstruction is recommended to stabilize their knee and to allow them to go back to cutting and pivoting type activities. And also, reconstructing the ACL is protective to the meniscus and to the cartilage. Non-operative treatment is typically reserved for older, lower demand individuals who participate in a physical therapy rehab program and build up quadriceps strength, and then can function in life without the knee feeling unstable on them. To fix the ACL, we have to reconstruct it. We historically used to repair it, but that had a high failure rate. Some studies are coming out showing newer techniques on repair, but still the workhorse of treating an ACL injury is reconstruction, which means we need to recreate a new ACL. So we have to take a graft from somewhere. There's two large groups for graft: from yourself, called autograft, or a donated piece of tissue called allograft. For younger athletes returning to competitive sports, we want to use your own tissue or autograft because that shows a lower risk of re-rupture in our longer term studies. For an older, lower demand patient, using allograft is acceptable, but you can also use autograft for them. And then in using autograft and choosing the graft from you, there's three main grafts we use. What we call BTB, or bone, patellar tendon, bone, taking the middle third of your patellar tendon, or you can use part of your quadriceps tendon, or you can use your hamstring tendons. And there are pluses and minuses to all three of those grafts. All three of them are acceptable and will give you a stronger ACL than your native ACL. But they all have pluses and minuses to them. So it's important to talk with your surgeon about your specific situation and your goals for your future. ACL recoveries in their entirety are quite long. For return to competitive contact sports, it's a 9 to 12 month time period, determined largely by return to play testing and making sure they've built up the leg musculature to protect the graft. Initially, they'll have protected weight bearing, and we'll work on restoring full range of motion of the knee, and then we'll work on building up strength, and then progress to more agility type maneuvers and return to sports specific drills. high school and collegiate athletes with an ACL rupture are expected to get back to 100% and full return to sport at a high level. It does take a while. It is 9 months to a year before you return to your sport, but you do return typically at the same level that you were playing at. And we have plenty of high school athletes that then go on to play Division I competitive collegiate sports. And there are plenty of professional athletes also playing on ACL reconstruction. The ACL reconstruction is an outpatient procedure, so you come in and you go home the same day. It's typically a couple-hour procedure, but you do need to allot the larger part of the day for being in pre-op, your surgical time, as well as the post-op PACU recovery. After ACL surgery, we want you up and moving immediately. That will help decrease the risk of surgical complications such as a blood clot. But depending on your surgery and on whether or not you had any meniscal issues that were addressed during the time of surgery, initial weight bearing could be protected, as well as range of motion. Physical therapy is a big part of recovery from an ACL reconstruction. Initially, it's necessary to normalize the knee, regain range of motion, and in the middle phase of the recovery, it's to build strength, and then at the end of the recovery, it's to build you back up to cutting, pivoting, and high energy maneuvers. Unfortunately, it is possible to re-injure your ACL after you've had it reconstructed. We know from studies in the lab that the graft is actually its weakest. It's 6 weeks post-op as your body goes through a process called ligamentization, where it takes the tendon graft you use and creates or rechanges it into a ligament. And then afterwards, if you return to play too quickly before you have built up the muscular strength to protect the graft, you can re-rupture it. Unfortunately, you can also just re-rupture it having done all the right things. That would put you into a revision reconstruction setting, which again, unfortunately, is harder the second time around. You need to take into consideration what graft was used initially and then pick a second graft. You need to take into consideration other technical factors such as bony alignment, tibial slope, or other reasons why they could have failed to try to prevent a second failure again.